Okay, this is lecture 1 of 2 about cardiovascular problems. My favorite topics, perhaps yours. Let's get started. So it's important to understand just how much blood exists in the capillaries. You can see that the effective cross-sectional area of the aorta is 2.5 centimeters. But look at the effective cross-sectional area of the capillaries. When you add up all the capillaries together, they have a cross-sectional area of 2,500 square centimeters. It's a huge area, right? The other relative sizes are listed here, but the capillaries contain the majority of the blood. Also, it's at a much lower pressure, right? In fact, the arterial pressures are the highest in the body. And as we get down to the capillary level, the pressure really falls off dramatically. The hydrostatic pressure, that is, the blood pressure. When we get to the capillary, other pressures are at work. Those are the oncotic pressure and the osmotic pressure. Those are the two pressures that work at the capillary level to move fluid and particles in and out of the bloodstream. Now, we can get an idea about velocity of blood flow when we look at the comparison between flow and area. So velocity is directly proportionate to flow. So the higher the flow, the higher the velocity, the higher the flow. I mean, either is true, right? But velocity decreases as the area increases. They're inversely related. And that makes sense, right? The velocity is going to be much slower in the capillaries than it is up here in the aorta and the large arteries. Okay, that's an important component to remember as well. Now, what determines flow? Well, the very important component of flow is not the pressure, but rather the pressure difference or the pressure gradient. Okay, and that's part of Ohm's law. Ohm's law says that flow increases with an increase in the pressure gradient, and flow decreases as the resistance goes up. All right, so you don't have to be able to do the math here, but you have to remember that anything that's above the line has a direct relationship with flow, and whatever's below the line has an inverse relationship. That's an important thing to remember. Basic math, right? Now, let's talk about turbulence of blood flow. We all like to think that blood just flows through the vessels without any turbulence whatsoever, and that's just not the way that normal blood flow works. Physiologists and engineers and people like that use Reynolds number, or RE, as the tendency for turbulence to occur. All right? When we have blood flow, it doesn't move like this. It moves like this, where the center column goes fastest, and then there's a little less speed on the next column out, and then it's even slower as the blood flows across the endothelial lining. So the turbulence is the proportionate velocity and flow with the diameter of the vessel. Okay? So the turbulence is proportionate to the velocity of flow and the diameter of the vessel. Turbulence is inversely related to the viscosity. So the more viscous the blood, the less the turbulence. The higher the viscosity, the lower the viscosity, the higher the turbulence. And you can make that make sense in your head. A gel is going to move through a tube which with much less turbulence than water or something, that is less viscous. So all of that makes you wonder about resistance, right? I'm sure it does. Well, resistance is one of those funny things that we can't really measure. We have to calculate it. And when we calculate it, we get this bizarre unit of referring to resistance, and that is dyne seconds per centimeter to the fifth. You may also see it written as dyne second centimeters to the negative fifth, which just means that the centimeters to the fifth is above the line, and the negative sign means that it's inverse, right? You remember all that from high school. So these units are really weird, but you'll get used to dealing with them if you're a critical care nurse or acute care nurse practitioner, because we use them all the time when we talk about systemic vascular resistance and pulmonary vascular resistance and things like that. Now, the next thing to keep in mind about blood flow is that it increases exponentially with the vessel diameter. So the bigger the vessel, the much more blood flow occurs. Okay? And the reason for that is this exponent. So remember, anything above the line is proportionate to, so flow is F. And as the radius of the artery increases, the flow dramatically increases because the radius is taken to the fourth power here. Now, what slows down flow? Viscosity. Viscosity is the one thing that decreases flow. But the other thing to remember is that the length of the vessel also is inversely related to flow. That makes sense too, right? The flow will be decreased the longer the distance is that it has to go. So those are things for you to keep in mind as we're talking about hypertension and shock and cardiac output and all those kinds of things. Now we're going to switch gears a little bit and talk about peripheral vascular disease. Remember that peripheral vascular disease is sort of a all-inclusive term for arterial and venous disease that occurs in the extremities. Now, it's very rare for someone to have upper extremity vascular disease. We don't see DVTs in the upper extremities, and we rarely see arterial disease in the upper extremities, which is kind of weird, right? It's just bizarre that vascular disease doesn't affect the upper extremities. Now, we do see DVT in the upper extremity if there's some instrumentation of the upper extremity vessels, subclavian lines or things like that. But by and large, we don't see arterial disease in the upper extremities. In the lower extremities, we do. Now, remember the anatomy that we have to think of as you're going from outside to inside. You access nerve first, then artery, then vein, and then the lymph. So the nerve is out here, the artery is here, the vein is here, and the lymph is furthest to the median aspect. And that's important when you're putting in lines and doing things like that. Now, let's talk about the differences between arterial disease and venous disease. You learned these in undergraduate, but it's important to remember them now because now it counts, right? Now you need to be able to differentiate these things if you're a nurse practitioner, and this is how you do it. So typically, venous disease is painless. There's no pain that occurs with chronic venous insufficiency. You get good circulation. The blood flow gets to the distal extremity very well. But because of some obstruction to flow, whether it's obesity or some other reason, frequently it's obesity, there is a an impediment to flow getting back to the heart. Well, the blood has to stay somewhere, and it just stays in the distal extremities. So again, painless, warm, normal pulses, edematous, you'll see dark pigmentation, and late in the disease, you can have ulcerations that are also painless at the ankles, either in the medial or the lateral aspect of the ankles. Now, contrast that with arterial disease, which is a totally different story. Arterial disease causes pain because there's not enough blood flow to the extremities. I had a guy on the treadmill a couple weeks ago who had seen his primary care provider for some time. He was a middle-aged guy, he was like 45 or so. Had seen his primary care provider and told him about this leg pain, and he had had a neurology consult, and all these other people had seen him. Well, nobody stopped to take a history and know that he was a lifelong smoker and that he really had claudication. Every time he walked, he got pain in the legs. Nobody did that. Nobody went through that one little step of actually talking to the patient and getting a history. So he gets on the treadmill and his legs are killing him. The further he goes, the worse the pain is. Well, that's claudication. And that describes arterial disease. Now, we may also see cool extremities if the blood flow is really limited. We often see diminished or absent pulses, and that's why we have to get Doppler devices and check for pulses, and particularly in these patients when they undergo surgery, we want to make sure that they don't have a ischemic extremity or something of that nature. No edema typically occurs with this. Often the skin is pale or even red, that rubor that occurs with chronic arterial insufficiency. Remember that the extremities are usually thin. They usually have thin skin, shiny, hairless, and then there may be ulcerations at pressure points. So here are some examples. Somebody has shoes that rub right here. He has arterial disease. Again, not edematous, but he gets this arterial insufficiency ulcer. You can see here this extremity is very pallorous, right? Is that a word? Pallorous. It has pallor. There's very little coloration to it. And then here's another example. This is actually purple toes, but we'll talk about that in a different setting. Purple toes, well, I'll talk about it now. Purple toes often are associated with emboli from the arteries, from the aorta. When we do cardiac catheterization or some other arterial instrumentation, sometimes we knock off pieces of cholesterol, and those embolize to the distal extremities, and you end up with purple toes like that. Here's an example of rubor, so you can see how red this is compared to this extremity. And there's ulcers here, again, at pressure points where something is rubbing against those toes. Now contrast that with what we see in venous disease. Here's varicose veins and spider veins. You can see the spider veins here. And varicose veins are where the valves in the veins that keep the blood from refluxing fail. And so blood refluxes down lower into the vein. That increases the volume of the vein, and you get that typical varicosity. So these are pictures of chronic venous insufficiency, and I want you to recognize a couple of things. First of all, obesity, right? So people with big bellies have an impediment to blood flow returning to their heart, and that blood flow limitation is from their big belly. It puts higher pressure, intra-abdominal pressure, on the vena cava, and that means that the blood volume has difficulty returning back to the heart. So these patients need to keep their legs elevated at night, and they usually notice that their ankles are much thinner in the morning than they are at the end of the day. nurses, big occupational hazard here. That's why you got to wear those support hose. Hate to say it, but. The other thing that you should notice is this dark discoloration that only goes to the knee and is associated with the larger diameter of the leg here. So that dark pigmentation that you see even more pronounced here is an indicator of chronic venous insufficiency. That's really, that's how it happens, is from chronic venous insufficiency. It causes this hyperpigmentation, and that's what it is. Here are the venous ulcers. These venous ulcers are painless, believe it or not, and they're just ugly and they need treatment. So usually, we send these patients to the wound center. They put Una boots on, tight wraps that keep the venous pressure to a minimum and allow for healing of that ulcer. This is a more dramatic example, and if you look at the notes of this slide, you'll see the description, but I've seen this a million times as well. As that venous insufficiency worsens, the skin takes on certain characteristics, right? We talk about the dark pigmentation and all that, and there is some of that happening here. But the skin really suffers as well, and you get this this scaling that happens, and it's typically not all the way down to the ankle. It's usually somewhere in the higher pressure areas of the leg. All right, so that's peripheral vascular disease. Let's talk about blood pressure now. I know you want to. So blood pressure has a whole bunch of different factors that influence it, right? There's the cardiac factors like the heart rate and the contractility. There's the circulating volume that goes into it, salt, aldosterone, etc. There's hormones like vasodilators and vasoconstrictors that contribute to this. There's peripheral sympathetic receptors that contribute to the blood pressure. There's central nervous system contributors, and then there's local effects as well. All of these things mean that we have to manage blood pressure in multiple ways. And we used to start with a single antihypertensive. Back when I first started doing this, the goal was to get people to take one pill a day. Well, the problem with that idea is that it fixed your blood pressure, but you couldn't get out of bed. You felt awful. And so we abandoned that, which was a stupid idea to begin with. We thought we were doing a good job, right, by trying to make it easier to manage your blood pressure. But what we now know is that it takes 3 to 5 antihypertensives sometimes. 3 to 5. Don't be afraid to have people on 5 different antihypertensives at lower doses so that A, you control the blood pressure, and B, you don't feel terrible, right? Well, when we use drugs like ACE inhibitors with beta blockers, with vasodilators, and with alpha-1 blockers, or better yet, when we have a beta blocker that has alpha-1 properties, like carvedilol, world's greatest drug, then we can start to attack the blood pressure from multiple different angles and get better control. And patients don't feel awful. So I just want you to see the kind of treatments that we can affect at each of these steps with the drugs that we have available. Now, understanding hypertension means that you have to understand the renin-angiotensin aldosterone system. I never learned it when I was an undergrad because this was just overwhelming to me. I didn't feel like learning it, and I should have, because now it looks like this, and that's a mess with all these non-ACE pathways, blah, blah, blah. So let's just focus on this, all right? I want you to understand this is pretty easy. There's a substance called renin excreted at the kidney that converts angiotensinogen into angiotensin 1. Easy enough, right? That's how the whole thing starts. And then when we convert angiotensin 1, we have to use angiotensin converting enzyme. Sound like a medicine? I think it does. And that angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. Now, what we learned more recently is that, and by more recently, I mean in the last 20 years, but what we now know is that there are non-ACE pathways. There's other ways for angiotensin 1 to get converted to angiotensin 2 that don't involve the angiotensin converting enzyme. Once we get to angiotensin 2, that causes vasoconstriction, all right? But it also stimulates aldosterone. And when aldosterone gets released, now we get into deeper problems because now the kidney holds on to sodium, and along with sodium goes water. And that increases the blood volume, and together that vasoconstriction and the sodium and water retention lead to an increase in blood pressure. This is a very powerful step in treating hypertension. When we give aldosterone blockers like spironolactone or Inspira, we really dramatically reduce blood pressure in patients who have resistant hypertension. This is, now that we know this over the last 10 years or so, this is really dramatic. We used to think that it was only people with hyperaldo, right? Only hyperaldosteronism, which is a very rare clinical condition with super low potassium and high sodium and all that. We used to think that was the only condition that would benefit from those aldosterone agents, anti-aldosterone agents. But it turns out that they are very useful in controlling people's blood pressure when other medicines don't. So I can tell you stories about patients who I've had on 5 medicines. I had them on, dihydropyridine, calcium channel blocker, beta blocker, ACE inhibitor, or ARB, an angiotensin 1 blocker, and had them on all these medicines and still couldn't control their blood pressure. Added a tiny dose of spironolactone or Inspira, and their blood pressure came down very nicely, and I was able to get rid of some of the annoying medicines that they were taking before. So this is an important thing that we've been talking about at the American College of Cardiology meetings for the past couple of years, and we've really seen a dramatic change in how we manage blood pressure effectively now. Remember, when you're a primary care provider, if you're treating hypertension, it's not good enough to just put them on a medicine and call it a day. Most patients with real hypertension need 3 to 5 medicines. 3 to 5 medicines. So you got to manage their blood pressure, and we're trying to get it down to less than 120 over less than 80 if you're under 60 or so, under 60 years old. All right, so let's look at chronic hypertension and how that's associated with atherosclerosis. Remember that when we have hypertension, that puts some extra strain on the heart and the arteries themselves. That increases the myocardial work. The heart responds with the cellular adaptation. Remember we talked about that? The cellular adaptation of hypertrophy. There's all sorts of cellular adaptation strategies. There's atrophy, there's hypertrophy, there's metaplasia. Remember all those? Well, the cellular mechanism here is hypertrophy. And when we get hypertrophy, that's good in the short term, but it eventually leads to diastolic heart failure. All of these things together can increase myocardial oxygen demand, and that can cause chronic stable angina or acute coronary syndrome, depending. We can also increase our likelihood of having aneurysms. The effects of hypertension on kidneys are also great. right? One of the together diabetes and hypertension account for about 80% of all chronic renal failure in the U.S. Hypertension is less than diabetes, but it's still a huge number. It's still a huge number. It's like 34% or something like that. So we need to treat the blood pressure aggressively. Blood pressure of less than 120 over less than 80 in patients who are under the age of 60, 70, pick a number. All right, but we want to address the blood pressure because we don't want the kidneys to get ischemia and then atrophy and cause end-stage renal failure. The brain gets an effect from hypertension and atherosclerosis too, because of increased blood pressure causing higher incidence of hemorrhagic stroke, and all of the vascular issues that are associated with hypertension can also lead to ischemic stroke too, right? Which is the most common of all the strokes. And then, of course, the eyes can have an effect from chronic hypertension as well, and we certainly don't want people becoming blind. So those are all the reasons that we want to treat hypertension aggressively. Remember earlier I said that when we have high blood pressure, our heart responds with the cellular adaptation mechanism of hypertrophy. Hypertrophy seems like a good idea to the cells, but over a long period of time, that makes everything worse. And the disease that we refer to as being caused by hypertension is hypertensive heart disease. It's the body's response to chronic hypertension, which is thickening of the left ventricle. Along with that goes an increase in aldosterone, which causes sodium retention, water retention, edema, higher blood pressure, all that stuff. And it's sort of a loop that never closes. The other thing that happens is that the heart hypertrophies, that thickness occurs that causes the heart to not relax well. When you have ventricular hypertrophy, you can imagine that there's a lot more energy used to contract it, and it doesn't relax very well. Think about the muscle head at the gym, right? He's always pumping iron and can't sit down. He's always yelling and carrying on, being annoying. That's because he's muscle bound and can't relax. The same thing is true with the left ventricle. When it's muscle bound, it can't relax very well. That means it doesn't fill well. And when it doesn't fill, the blood backs up into the lungs and causes heart failure. It's called heart failure with preserved ejection fraction, or diastolic heart failure. Eventually, though, this left ventricular hypertrophy burns itself out, and you get dilation of the ventricle. The ventricle dilates, you get mitral valve regurgitation, you get heart failure of reduced ejection fraction, and it's a big mess. So we really hope to prevent hypertensive heart disease. Once we get to this stage, we have limited options. We still want to treat the blood pressure aggressively, but there's been end organ damage already. So let's try to prevent it, right? Try and get these patients treated with antihypertensives quickly. Now, those things that we just talked about are typical of primary hypertension or essential hypertension. There are secondary causes of hypertension as well. And think about things like renovascular disease, right? So when you have a blockage of the blood flow to the kidneys respond by being hyperaldo and increasing the renin-angiotensin aldosterone contribution, and it raises the blood pressure, and it's hard to treat. Secondary causes of hypertension often cause us to have a lot of difficulty managing the blood pressure until we fix the underlying cause. Even so, when we fix the underlying cause, like renovascular disease and renal artery stenosis, we still oftentimes have patients on these antihypertensive drugs, which is kind of weird. I want you to notice that sleep disordered breathing, principally obstructive sleep apnea, is a huge contributor to uncontrolled hypertension. Huge. It's very difficult to control somebody's blood pressure when they have sleep apnea that is untreated. It's very, very difficult. And that's something that you'll certainly encounter clinically. Now, let's talk about renal artery stenosis. There's two kinds. There's fibromuscular dysplasia, which typically happens in young women. When we identify somebody with uncontrolled hypertension who is in that age range and young female, we usually do some workup for renal artery stenosis. And once we fix that, we are successful in 82 to 100% of patients, but we only cure their hypertension about 60% of the time. Most of these patients, even after we restore blood flow to the kidney or full blood flow, we still have trouble keeping their blood pressure under control without medicines. It's easier to control, but we still need medicines. So that's the kind that we see in young women. Keep that in mind when you're seeing young people in the office and they have very difficult to control blood pressure or any hypertension to begin with. Then there's atherosclerotic renal artery stenosis. This is 75 to 90% of all renal artery stenoses. This is usually men who are older, and this is the result of atherosclerosis. Okay? It can lead to end-stage renal disease, and even though we only cure hypertension 30% of the time when we fix this, we need to do it to preserve the kidney and avoid end-stage renal disease. So the way we screen is with highly sensitive tests, and so you can see that just hearing a bruit is poorly sensitive. The gold standard is angiography, but we get a very good sense with renal duplex imaging and with MRA or magnetic resonance angiography of the kidneys. So very high sensitivities. And MRA is also very specific, but it's also very costly. So these are the decisions that you have to make when you're treating it. Here are pictures of fibromuscular dysplasia. You can see it has this weird sort of tortuous appearance. And when we put a stent in there and fix it, we restore the blood flow, and it looks great. Here is the classic look of atherosclerotic renal artery stenosis. You can see the normal size vessel is here, and it gets down to a very narrow area here. And so when we put a stent in there, it restores blood flow, and we get what looks like a normal artery after that. Oops, sorry. Pheochromocytoma, I don't even know why we talk about this. It's so rare. Everybody talks about it in undergraduate programs, and you'll never see it. I've been a nurse practitioner for 27 years, a nurse for 30 years this year, and I have seen pheo once. It just doesn't happen. But we spend so much time teaching students to understand pheo. It's ridiculous. When you're teaching pathophysiology as a nurse educator, just skip the pheochromocytoma or put one slide up about it like this. All right? It's a disease that happens when there's a tumor in the medulla of the adrenal glands, and it causes an increase in catecholamines, and that causes these weird symptoms like intermittent hypertension, palpitations, sweating, anxiety, and it may be triggered by certain tyramine containing foods, but maybe not, and it's just a really hard thing to figure out. But don't waste your energy because you're never going to see it. Okay. Pheo screening is pretty easy to do with just plasma-free metanephrines. And when we don't see plasma, or when we do see plasma metanephrines, I'm sorry, I have to rephrase that. We have a 99% chance of finding plasma-free metanephrines when someone has Pheo. That's what that number means. But just because they have it, there's still a 11% chance that they don't have a Pheo when they have high plasma metanephrines. You'll learn about sensitivity and specificity at another time. I don't want to waste your time thinking about that in this course. Hypertension in children, like adults, it's most often asymptomatic. And so that's why you have to screen for it. But unlike adults, the most common cause of childhood hypertension is from a secondary cause. The renovascular coarctation of the aorta is very high probability of hypertension. Congenital defects, metabolic diseases, etc. Quickly, let's talk about hypotension. There are reasons for hypotension. Arrhythmias like bradycardia can cause low blood pressure and low cardiac output because, cardiac output is stroke volume times heart rate. Well, if your heart rate's only 30, then that's not a very good cardiac output if you don't have a great stroke volume. But tachycardia can also do the same thing. Maybe you have a heart rate of 200, but now when your ventricle contracts, it's going so fast that it doesn't have enough time to squeeze out enough blood, so your stroke volume falls dramatically. And over a long period of time, tachycardia can lead to heart failure. And it certainly can cause hypotension. In fact, that's how we decide if we're going to buzz you, right? If you're in the emergency room and you're hypotensive and your heart rate's 200, then you get electricity to get you out of that because we don't like the hypotension that goes along with it. There's structural heart disease that can lead to hypotension, ischemic heart disease, pericardial disease, cardiac tamponade, the list goes on. Hypovolemia is another important thing. Now remember that orthostatic hypotension is a function of hypovolemia. When you're orthostatic, your blood pressure is fine when you're laying down, but when you stand up, it drops. That's because you got to fill up the tank. You got to put more fluid in there. And just filling up the tank usually fixes it. But in older adults with neurologic impairment, it becomes very difficult to manage their orthostasis. Drugs also contribute to that. That's important to know. And then there's vascular causes of hypotension, like pulmonary embolism, certainly causes all sorts of downstream effects that lower your blood pressure. But there may be autonomic dysfunction, as I alluded to with the nervous system problem causing persistent hypotension, and a lot of drugs that we use, right? Including the antihypertensives. We get into this trouble all the time. When the patient's laying down, their blood pressure is 200. When they're standing up, it's 50. And, what are you going to do about that? It's a very difficult, challenging problem. Let's talk about atherosclerosis now, shall we? But first, let's talk about cholesterol. Now, remember that LDL cholesterol is low-density lipoprotein, and this is the cholesterol form that is transported from the liver to the cells of the body. Okay? Sometimes it collects in the arteries, and we'll talk about how that happens and why that's important, because it causes an increased risk of stroke and MI and vascular disease and things like that. So HDL, we used to call the good cholesterol. Well, we said it was good because the role of HDL is to transport cholesterol from the arteries back to the liver to process and get rid of. We called it reverse cholesterol transport, which sounded like a great thing. So we designed all these studies to say what would happen when we raise the HDL cholesterol. Guess what? Nothing good happens when you raise the HDL cholesterol. Well, it makes sense that we would have thought that, but it also makes sense that it's still just cholesterol. So the fact is, it's in the bloodstream and it's indicative of high cholesterol levels elsewhere in the body. Okay? We don't have a better explanation than that. We just know that it wasn't the right target to prevent events. So don't tell your patients that we want to raise your HDL cholesterol. First of all, it's very hard to do. Exercise, even marathon runners can have an HDL in the 20s. Exercise is said to raise your HDL, but like so much that we tell people about exercise, it's just not true. Exercise doesn't help you lose weight. It's never been shown to help you lose weight, and it doesn't raise your HDL appreciably. Now, that being said, I will tell you there is nothing more important for good cardiovascular health than regular exercise. 100% agree that it is the most important thing for your cardiovascular health and your ability to not use assistive devices as you get older. There's no question about that. But don't tell patients it's going to help them lose weight. It just doesn't do that. It's the food you eat that makes you fat. I know, because, of the food I eat. All right, let's talk about triglycerides. Triglycerides are the transport to the fat cells. All right, they transport fats to the fat cells where they get stored as body fat. These are not affected by low cholesterol diets, right? We don't put people with hypertriglyceridemia. I can't say that word. I don't know why I stopped being able to say it. Hypertriglyceridemia. We don't fix hypertriglyceridemia by putting patients on a low-fat diet. It doesn't work. We have to get rid of sugar and alcohol. That is what lowers triglycerides. And by the way, when we lower the triglycerides, we raise the HDL. All right? So maybe all along, it wasn't the HDL that was such a good marker, but maybe it was lowering the triglycerides that was the good marker. I mean, there's been some studies recently that suggest that. The other thing to remember is that when the triglycerides are super high, like more than 1,500, and by the way, normal triglyceride level is under 150, right? When it gets 10 times higher than that, you're at risk for pancreatitis. The pancreas cannot take a joke, right? It never has been able to, whether you're operating and you're told to stay away from the pancreas, or whether we're talking about hypertriglyceridemia, we cannot joke with the pancreas. It will not take a joke. The last thing I want you to know about is apolipoproteins. So HDL and LDL and all that stuff don't just float around on their own. They have to be attached to a carrier protein, and that is the ApoB or ApoA carrier. These are what deliver, they're the transport that delivers the LDL particles or the HDL particles to their final destination. There are different subsets of ApoB. There's ApoB48, ApoB100. ApoB100 is the one that we're interested in, and it's the thing that carries LDL, VLDL, and intermediate density lipoproteins. Okay? The ApoA1 carries the HDL particles. The best assessment that we can get of cholesterol transport in the body is the ApoB100. So measuring ApoB is a great thing to do, but we rarely use it clinically because guess what? It really correlates very well with the LDL cholesterol. And that's the target that we have with medicines anyway. So most people just ignore all that stuff, except in the advanced lipid clinics. We just worry about the four basics: total cholesterol, which we can ignore, LDL, HDL, and triglycerides. Now, lipid metabolism, very complicated. This is such a cursory overview that I'm giving you. It's not even funny. Essentially, what happens is when you eat, you take in dietary fat, it gets digested, and it gets picked up in the gut, right? You get these little micelles that convert to triglycerides. Triacylglycerol is another word for triglycerides. And these fatty acids that are attached to the triglyceride molecule get absorbed in the gut as chylomicrons. And these chylomicrons go to the liver, and you may see some in the circulation as well. These chylomicrons then become chylomicron remnants, and the rest of the chylomicron gets converted to VLDL or to intermediate density lipoprotein, or it gets sent out as LDL cholesterol. Okay, and then it goes to the cells of the body, and when the cells have had enough, they send the excess back in the form of HDL. All right, that is a very, very basic understanding of what happens. Remember the exogenous pathway, this is dietary fats, and the endogenous pathway, this is the stuff that involves the liver, okay, is in red. So a couple of important things. Remember that your body has to have cholesterol. You have to have cholesterol. There's no two ways about it. But too much is not good. Now the question is, what's too low? If we put somebody on cholesterol medicine and we lower their LDL cholesterol from 110, and we're trying for a goal of less than 70, and we get down to 40, is that too low? I don't know. Nobody knows. Nobody knows. Now, let me just quickly pull together some of your knowledge from high school and from college. Remember that when we process glucose, we get the first step of converting it to pyruvate, and then we get acetyl coenzyme A, okay, or acetyl coenzyme A, take your pick. A lot of that goes into the Krebs cycle for ATP production. But another arm of the acetyl coenzyme A processing or metabolism goes to produce cholesterol. And the way it happens is that it goes through a whole bunch of steps here where you get acetyl-CoA plus acetyl-CoA, aceto-acetyl-CoA. It's a weird thing. But anyway, you go through all these steps, and eventually you get to this step where the acetyl coenzyme A gets combined with the HMG coenzyme A synthase, and that converts to HMG coenzyme A reductase. Does this sound familiar to you? Have you heard of HMG coenzyme A reductase? Maybe not, but I'm sure you've heard of HMG coenzyme A reductase inhibitors. And this turns out to be the step that we are using for with statins to reduce LDL cholesterol. When we use a statin, it is an HMG coenzyme A reductase inhibitor, and we inhibit cholesterol production with that. Now, what increases coenzyme A reductase? Well, one thing that does it is insulin. And this is why the lipids get out of control and the cholesterol gets out of control when somebody is diabetic. because insulin causes an increase in the HMG coenzyme A reductase. Okay? After a whole bunch of steps, HMG coenzyme A reductase goes to cholesterol. And why is cholesterol important? Among other things, it's a component of cell membrane construction. When the cholesterol molecule is part of the cell membrane, it gives some structure to the cell membrane, gives it some firmness, so it's not just a big amoeba-like, jelly-like thing. It gives some structure to the cell membrane and allows for transport of substances through the membrane. It also leads to steroid hormone production. Your body cannot make steroid hormones without cholesterol. So all of your adrenal hormones, cortisol and aldosterone and all the rest, and estrogen and testosterone require cholesterol to make them. The other big important thing is bile salts. So you remember in that step here, when the cholesterol gets back to the liver, it produces bile acids, and those bile acids go into the duodenum and allow for emulsification. You remember what emulsification is, right? If you're in the kitchen and you want to emulsify two liquids, you want to combine them so that the oil doesn't sit on top of the vinegar. Well, one way to do that is to use an emulsifier. And an emulsifier could be bile. Well, you wouldn't want to put bile salts in your salad dressing, but how about mustard? Mustard does the same thing, right? That is a emulsifier that will allow the polar compound and the non-polar compound to mix together. All right? So all that cholesterol stuff finally comes to bear at the cellular level in the vessel when the monocyte becomes a macrophage and the receptors here take up lipoproteins. Remember, the macrophage is really just a white blood cell that has migrated from the vessel and out into the tissue. And so this now is a macrophage. It picks up these lipoprotein particles and envelops them and absorbs them. And these now become foam cells. They're foam cells. We call them foam cells because they look foamy under a microscope because of all the lipid droplets that they have inside of them. This is the very, very beginning of the atherosclerotic process, these foam cells. So what happens then is the foam cells become they inundate the intima of the vessel wall and start to pick up more lipid, which makes them grow in size. And this now grows the plaque even larger. Now, I want you to notice something here important, and that is the fact that all of this stuff is happening in the intima of the vessel without impinging on the lumen of the vessel. You see that? So here's a normal vessel. This vessel still looks normal, but there's all this plaque that's going on. Here there's a ton of plaque, and we're just now beginning to see the lumen of the vessel be involved. This is very late in the disease, until finally there's some rupture of plaque that happens. All this schmutz from this lipid pool leaks out into the vessel and causes thrombosis, heart attack, dead, end of story. Okay? That is the way that vascular disease works. Now, we have some other tools in the arsenal that decrease the chance of that happening. Your body works with the endothelium of the arteries to release nitric oxide or NO. And when your normal endothelium releases nitric oxide, it allows it to have better vasomotion. It can expand and contract and move and participate in life. It gets off the couch and it does things useful. All right. That's what nitric oxide allows the endothelium to do. When the endothelium is healthy, it produces nitric oxide, which reduces shear stress and allows for relaxation of the arterioles. That's all good stuff. We want nitric oxide, but it only happens in healthy endothelium. We can give ACE inhibitors that will improve nitric oxide performance and make the endothelial lining healthier. So that's our goal. This back to the atherosclerosis thing again. You can see just another pictorial representation of how this process works. I won't go through it again, but I do want to again reiterate the importance of knowing that the lumen of the artery remains the same size for a prolonged period of time in coronary disease. So let me back you up and tell you how we first discovered this. In the 1950s, they were doing studies. The Bogalusa heart study was done in the 50s, or started in the 50s, where they studied children who were killed in Bogalusa. Is that Alabama? Mississippi? I don't remember. But anyway, Bogalusa. They did posts on children, and they noticed that there were fatty streaks in the coronary arteries, even in these young kids. Soldiers who were killed in Korea, same thing. They could have fatty streaks in their arteries, and yet these patients hadn't developed coronary artery disease in a clinical sense yet. Well, fast forward to around 2000, the late 90s, a guy named Steve Nissen, who's a cardiologist, I think he's still at Cleveland Clinic. He may have moved on by now, but sort of world famous cardiologist, did this study where they took donor hearts, right? So these are predominantly 20-somethings who had brain death and they were going to harvest their organs. Well, 20-year-old kid you wouldn't think has coronary disease, right? Well, in fact, they did coronary angiography, and look how nice and smooth this vessel is. It just looks beautiful, right? I mean, these are gorgeous coronaries. You would all want to have coronaries that look like this as well. And where this arrow is where they put an intravascular ultrasound catheter. And look what they found. There's this huge lipid plaque that occurs right here. Totally normal, rounded, normal coronary artery that shows up very nicely on the angiography, but this plaque is in the wall of the vessel. It doesn't show up on angiography yet, but it's clearly there, and it is ugly. So even in 20-year-olds, we have seen the development of this coronary artery disease that doesn't become clinically evident for another 20, 30, 40 years, but it starts early. And the take-home message of that is that the cholesterol plaque, we used to think, would just continue to impinge on the artery until it finally closed. We know now that this plaque can develop and be present for 20, 30, 40 years or more before it ever causes any narrowing of the artery. So listen to this. When we do a catheterization and we tell a patient they have clean coronary arteries, that is not the message the patient should hear. If they have risk factors and we see no evidence of blockage on the coronary artery, on the coronary angiogram, we should tell them that they still could have blockages. We have to make sure that you're managing all of your risk factors as best as you can. keep your LDL low, keep your blood pressure under control, don't get diabetes, don't get older, change your parent. Well, you can't do those things, but you know what I mean. We want to still manage their risk factors. Don't tell them everything's fine, you don't have coronary disease. Tell them everything's fine, you don't have any flow limiting blockages that would cause chest pain, but we still want you to manage your risk factors aggressively because you are at risk for developing worse blockages. Okay? So let's talk about those worse blockages. We'll talk about ischemic heart disease. So before we get into the classic discussion of arteries causing chest pain, let's talk about this dude named Prince Metal. So Prince Metal lived in the, I think, late 1800s, early 1900s. And he wrote a paper where he noticed that there were some patients who developed chest pain, and instead of having ST depression with their chest pain, they had ST elevation, right? This is the ST elevation that he saw. Now, why would that happen? Usually when you have pain at rest or pain with exercise, you have ST depression, and you only have ST elevation when you have an acute MI. But here's a subset of patients who had ST elevation when they developed their chest pain, and they weren't having an acute MI. That's what he described in his paper. Later, when catheterization was developed, we saw that there's a subset of patients, by the way, who had coronary spasm, where the artery would spasm and cause ST elevation on the EKG. And then we put two and two together and we discovered that Prince Metal's angina, which is chest pain at rest, is really just a ST elevation at rest because of coronary spasm. We treat this with calcium channel blockers, and that's usually adequate treatment for these patients. Let's talk, though, about the classic coronary artery disease. Now, remember that coronary artery disease is a continuum of conditions. At one end, and the end that we hope to have our patients at mostly, is chronic stable angina. This is where you have no chest pain any day of your life except when you're really stressing your heart. All right? You have, you're outside chopping wood, and 3 hours into it, you develop some angina. That's perfectly acceptable. That's not an acute MI. You have exertional angina at a very high level of exercise. I had a patient once, 20 years ago or so, who had chest pain while he was biking, and it never happened before mile 20. So he would ride for 20 miles, have chest pain, have to rest for a couple of minutes, and then he could keep riding and be fine. That's chronic stable angina. Okay? Chronic stable angina, where you're going to have chest pain with only super heavy exertion, and you could even predict it too. These patients can be managed with just sublingual nitroglycerin that they take before they're going to do some activity. That's the best that we can hope for when somebody has coronary disease. When we get into the acute coronary syndromes, we're talking about unstable angina and acute MI, which we now term non-ST elevation MI, or for acute MI, ST elevation MI. Okay? So unstable angina, or NSTEMI, is characterized by patients who were doing fine, thank you very much, and not having any angina. And then a couple of days ago, they started having some chest pain with exertion. And now this morning, they woke up with chest pain. Well, that's an increase in their symptoms. And now they have rest pain. That is, by definition, unstable angina. Okay? Chronic stable angina, only with exertion. Unstable angina, now it's new chest pain, or it's increasing in frequency, or now it occurs at rest. Those are the indicators of unstable angina. And then, of course, an acute MI is you wake up with chest pain, crushing chest discomfort, heaviness, pressure, tightness, feels like somebody's standing on your chest. Go to the emergency room, do an EKG. There's ST elevation in contiguous leads. Now you have to go to the cath lab and get a stent. All right. So chronic stable angina, we can often treat with things that lessen the demand, right? We either have demand that we can deal with or we have supply. Well, the way to fix the supply side of the equation is to increase coronary blood flow. How do we do that? Well, we fix the blockage or we do bypass. So dealing with the supply side of the equation is done in the cath lab or the OR. We can deal with the demand side of the equation by using drugs like beta blockers. Beta blockers, the world's greatest drug. What do? They do all the opposites of adrenaline. They decrease contractility, they decrease heart rate, they decrease blood pressure, they make the world a better place. Nothing better than beta blockers, right? They hurt nobody, almost nobody, and they are just the world's greatest drug. Use them instead of calcium channel blockers 100% of the time. Wonderful drugs. We can also use antihypertensives, vasodilators. Those things will also affect the demand side of the curve. Okay? So when we have somebody with chronic stable angina, we can give them nitrates for use when they're about to do something that they know is going to cause them chest pain. I had a patient the other day who had inoperable disease we were going to manage medically. And I said, so what sort of activities give you chest pain? He said, really the only thing, he was an elderly guy. He said, really the only thing that bothers me is when I walk to the mailbox or take out the trash. And I said, good, then here's the way we're going to do it. If that's the only time that you get chest pain, take a nitroglycerin 2 or 3 minutes before you do that. And I saw him back in the office. He said, that was the greatest thing you ever told me. He said, I have no pain now because when I'm going to do something that I know gives me chest pain, I just take that nitro and I'm good to go. So we can treat chronic stable angina by treating the demand side of the equation, lowering contractility, lowering heart rate, decreasing wall tension with nitrates and beta blockers. The acute coronary syndromes happen when there's a plaque rupture, right? Now we can have dramatic plaque rupture where everything falls right into the vessel lumen and that because that fibrous cap erodes through, or we can have sort of a slow leaking, right? When it slow leaks, that leads to non-ST elevation MI. When it abruptly leaks and all that clot forms in the vessel, that's an ST elevation MI. That's the way we think about it anyway. We don't know. That's just the model that we use to think about this. When we have an MI, it eventually looks like this. Now, the only way we get this picture is when everything has gone very badly for this patient. I flipped this picture upside down because for some reason they published it upside down. This is the posterior lateral wall, and this is where the infarct was. And you can see some damage in the form of this increased redness and inflammatory zone around the ischemic area. This yellow part, the pale part, is the ischemic area from an old MI. So remember that when we have myocardial infarction, we go through these stages that we can see on the EKG. The first stage that oftentimes we never get to see because it disappears within 15 minutes is these giant T waves, right? We get giant T waves in the affected leads as the very first EKG change. Usually it's gone by the time they get to the hospital, but in retrospect, sometimes we look at the initial EKG, and I've seen this happen before. When I was a brand new nurse, there was somebody in the emergency room who came in. I would have sworn that he was having a heart attack. We did an EKG and didn't see anything. The emergency physician didn't see anything. And then he continued to have chest pain. We repeated it, and he had this ST elevation. When the cardiologist came in, he pointed out that the patient on the initial EKG had these giant T waves, or what we call hyperacute T waves, and they had been missed by the emergency physician. I mean, patient did well. Everything was fine because he got thrombolytic back then, but still a little embarrassing, I think, for the emergency physician. After that 15-minute interval where you have the hyperacute T waves, then the ST elevation occurs. The next thing that develops within 24 hours or so is a Q wave. And as the Q wave develops, now the T wave also gets inverted. And then the ST segment starts to come back to normal. And eventually, after 48 hours or so, you'll have a Q wave and an inverted T wave. And this is how we tell that this is an infarct of indeterminate age. It could stay like this, from the 48-hour period until years later, or for the rest of the patient's life. We just don't know how long it has been that these occurred, right? The T wave will come back to normal, maybe, at some point. And when we see a Q wave and a normal T wave in those leads, then we can say that this is an old MI. When we still have the inverted T waves, we say it's an infarct of indeterminate age. Once the T wave goes back to normal, then we can say that it's an old MI. Okay? When we see persistent ST elevation like this that never goes away, that's associated with an aneurysm. We don't see that very often anymore because we usually fix these patients pretty quickly after they present with chest pain. Now, how do we use the laboratory values from cardiac enzymes and other blood tests? Well, when muscle dies, it releases the contents of the cells, right? Because there's no apoptosis that happens during this. During an acute MI, the cells burst open because the sodium-potassium pump fails. The cell swells. They burst open, and out comes all of the globins, right? The first one, because it's the lightest of all, is myoglobin. Now, the problem with myoglobin is that it's not specific to cardiac muscle. All muscle in the body has myoglobin. So if the patient comes into the emergency room and their serum myoglobin is elevated, it doesn't tell us if it's their heart or they just ran a mile and it's their thigh muscles that are the problem. We have to wait for more specific labs like troponin and CK. But the cool thing is, if somebody comes in within 6 hours, right, because this myoglobin peaks at about 6 hours, if they come in and they come in with this crushing chest pain, we don't see elevated myoglobin at 6 hours, then it's not a heart attack, right? It's not a heart attack. So that was the way that we used to deal with it when we only had CPK to deal with as well. But now that we have troponin really peaks pretty quickly at about 12 hours is when it comes up more rapidly. It peaks at 24 hours or so, and then it comes down over a period of about 7 days. CK used to peak at 24 hours and come down by 48 hours and was gone by 60 or 72 hours. We use these to help us understand how old the MI was and how big the MI was. We look at the area under the curve here, and that tells us the total CK the total troponin spill, and that tells us how big the MI was. Does that make sense? So that's a little bit about how we use the cardiac enzymes at the time of an acute MI or unstable angina. Now, remember that when this is just another explanation of the process that happens with acute MI. There's this atherosclerotic plaque, the lipid-rich core, a thin fibrous cap holding it all in, somehow ruptures because of shear forces, inflammation, or what have you. When that ruptures, the schmutz comes from that rich lipid-rich core and moves into the vessel lumen, where it stimulates the platelet aggregation and blood clot formation. When that happens, there's an abrupt decrease or cessation of coronary blood flow, and that is either unstable angina or acute MI. Okay. There's another explanation of it on this side that you may wish to look at as well. Last thing I want to cover is congenital heart disease. I'm not going to go through this in detail except to show you the major subclassifications. Before you do that, I want you to watch this video that's on the slides. Just click this and you'll be able to watch a video from 1951 that is just as relevant today as it was before. And this will tell you all about, and I love the guy's voice, you're going to like it too, but this will tell you all about the embryologic heart development. And when you understand how the embryology of heart development works, it will make much more sense to you how these abnormalities occur. So be sure to watch that and check it out. The first kind of defects that we're going to talk about are the acyanotic defects. This is where there's left to right shunting of blood. So it goes from the left heart, which is high pressure, to the low pressure right side of the heart. And that makes sense. That's the way blood flow should occur. The prototypical infant version of this type of defect is a PDA, where there's a communication between the pulmonary artery and the aorta. This is present embryologically all the way through fetal development. You have to have that so that you can send oxygenated blood to the lungs, right? Until you're breathing. And so this is supposed to close within 2 weeks of birth. If it doesn't, then the pressure, which is higher in the aorta than the pulmonary artery, or which becomes higher in the aorta than the pulmonary artery, will not change, right? You'll still have hypertension in the pulmonary artery because this blood is communicating here. That's a bad thing because heart failure, right heart failure, occurs. So that left to right shunt from the aorta to the pulmonary artery is a bad thing. Another reason that you can have left to right shunting or acyanotic heart defects is from an ASD, an atrial septal defect, or more commonly a VSD. And there are different kinds of VSDs. But when the left ventricle contracts, it squirts blood through that VSD into the lower pressure right heart. But now you end up with right heart problems because of increased pulmonary vascular resistance. Okay? There's AVC defects as well. But those are the reasons, those are the big reasons that you would have an acyanotic heart defect. Cyanotic defects are where there's right to left shunting of blood. Tetralogy of Fallot is the prototype here. And tetralogy of Fallot has 4 abnormalities. There's a high VSD, right? Very high, right underneath the overriding aorta, which is the second thing, right? It's in between the right ventricle and the left ventricle. It overrides both ventricles. There's pulmonic stenosis, where there's a decreased orifice through which the blood can flow. And then there's right ventricular hypertrophy because of all this stuff going on. So tetralogy of Fallot, very used to be a deadly disease that caused blue babies, right? And we talk about blue babies because there's unoxygenated blood going into the systemic circulation, which causes cyanosis. There was a fantastic movie about tetralogy of Fallot, about the first operation to relieve tetralogy of Fallot in these blue babies, and it was called Something the Lord Made. It also talked about Dr. Blaylock at Hopkins and his laboratory assistant Vivian Thomas, who is the only non-physician whose portrait exists in the rotunda at Hopkins. Fascinating story. I really encourage you to watch it. It'll bring a tear to your eye for a lot of reasons. Good social commentary as well about racism in America, and one example of partially overcoming it at Hopkins. All right, enough about that. Tricuspid atresia, where the tricuspid valve doesn't develop fully and the blood has to get to the lungs a different way. This is that thing about Something the Lord Made. You can watch a little preview about it here. I'm telling you, it is fascinating. Fascinating. There's obstructive defects that happen as well, like coarct. So coarctation of the aorta, which again is associated with a secondary form of hypertension, can be either preductal, before the duct, the ductus arteriosus, or postductal. And that needs to be repaired in infancy in order for the child to grow normally. Aortic stenosis, another obstructive defect. Pulmonic stenosis and pulmonary atresia. Hypoplastic left heart syndrome, where the left heart is this tiny little thing. Those are some of the obstructive defects. And then there's mixing defects, such as TGA, or transposition of the great arteries, or transposition of the great vessels, where the aorta supplies unoxygenated blood to the body, and the pulmonary artery supplies oxygenated blood to the lungs. Now that might seem weird. There has to be a way for the patient to survive this. How does the oxygenated blood, how does any blood get into the pulmonary circulation if the oxygenated blood comes back to the ventricle and then goes back out to the lungs? This is just a pulmonary loop, right? Well, the reason that happens is with this thing called congenital correction. So when it's congenitally corrected, there is an ASD that is present, and you have to have that in order for the you have to have some communication between the left and right heart in order to survive this. There's totally anomalous pulmonary venous connection, pretty rare. Truncus arteriosus, which is where you have this overriding aorta that supplies blood to the lungs and to the body. And that's really what I want you to know. I want you to understand those four congenital heart defect classifications and what they mean.